Hello and welcome back to the CSF Rheumatology Author Interview Podcast. My name is Professor Peter Nash from the Griffith University in beautiful downtown Brisbane, Queensland, Australia. And today we're very fortunate to be joined by Dr. Rishi Desai, who's an Assistant Professor of Medicine at Harvard Medical School and an Associate Epidemiologist in the Division of Pharmacoepidemiology and Pharmacoeconomics at the Brigham and Women's Hospital, which I think is in Boston. Welcome, Rishi. Great to have a chance to discuss this with you today, and thank you for giving up your time.
Great. Thank you for the opportunity. I'm really looking forward to our discussion.
Excellent. So can you just start off by two things, telling us a little bit about yourself, your interests and what you've been working on, and then maybe briefly what COVID-19 has affected your practice and how things are going in Boston.
Yeah, great. So, as you said, I am located here in Boston, Assistant Professor of Medicine at Harvard Medical School and a Pharmacoepidemiologist in the Brigham and Women's Hospital. So my research surrounds looking at medication safety and effectiveness once they hit the market. So we use routinely collected healthcare data from insurance records, for example, or electronic medical records, to look for adverse events that may not be seen in trials because they run for a short period of time and they have sample size limitations. So that's where my research is focused on. And your second question is about the COVID-19. So thankfully, things are on the mend, I hope, in the US. And so we are actually seeing more and more people out and about, and vaccination is going really well. So hopefully we'll have a better summer than the last one. But you never know with the variants and stuff. So. Yeah.
Excellent. So today we're talking about your paper recently published in the Rheumatology, that's the British journal. It's a population-based cohort study. It's looking at a very topical issue, the JAK inhibitors, and in this instance, VTE, which is one of those issues we want your opinion later, whether this is a class effect or a JAK2 inhibition effect. So be prepared. VTE associated with tofacitinib in patients with rheumatoid arthritis. So this is called the risk of VTE associated with tofa specifically in patients with RA population-based cohort study. Can you tell us a little bit about why you picked this particular area and just a bit of background about the JAKs and VTE?
Right. So we have been actually interested in this research question for a number of years. So this is our second publication, sort of the updated analysis. Our first analysis was actually presented in 2018, back in 2018 at the American College of Rheumatology meeting as a late-breaking abstract. That was our first analysis, but based on really early data, which limited our precision of our estimates. That paper was later published in Arthritis and Rheumatology in 2019. And then, but that only had information on 2,000 tofacitinib users because at the time the drug was not that widely used. And whenever we use these population-based cohorts, we have a few years of lag because data roll in a little bit late. And so we only had data up to, I think, 2015 or 2016 at the time. And so we were not able to sort of conclusively demonstrate a risk or no risk in that study. And so we decided to look at this question again when we had more data accumulating over the years, where tofacitinib use has actually slightly increased in the US, and we have now data up to 2018 for one of the databases, and so we decided to look into this question again. And why is this important? It's a question that's been on many people's mind for many years now. So first observation was, as you and your listeners will know, from baricitinib trial. There was a 4 milligram dose which had this signal of a number of extra events, if you will, for venous thromboembolism, which actually led the FDA to not approve that particular dose, and they went ahead with the lower dose of 2 milligram. developments after that have not been too encouraging. So Pfizer did this oral surveillance study for tofacitinib, which again showed a slight signal for VTE at the higher dose, at the 10 milligram BID dose. And so they actually were forced to convert everybody who received the 10 milligram dose to 5 milligram because of that. And so the oral surveillance trial is complete. They have the headline findings, the top line findings. They were recently released, where it doesn't say anything about the VTE, but it was a slight signal for cardiovascular events overall. And cancer. So the safety of JAK inhibitors is on many people's mind. And as a drug class, I mean, it's really appealing, right? Because for many years, rheumatoid arthritis patients did not have any sort of easy to take disease modifying medication, and JAK inhibitors come along, easy to swallow pills. But then the safety issues mount one after another, so that led us to really look closely at the data that we have accumulated based on patient experiences over the 6 or 7 years that tofa has been marketed in the US. And so that's why we were really interested in looking at this question to definitively rule out or rule in a signal that has been observed.
Excellent, excellent. Because to be fair, the oral surveillance hasn't been peer reviewed and published yet, and we're very keen to see that, because press releases are press releases, and we need to see the data. I've got a sneaky suspicion it'll be more than just MACE and malignancy. There'll be some serious infection and some hospitalization. So we really do need to see that. It's critical. And just before we get into your methods, Philip Meese published the VTE rate across all the tofa studies out to 10 years and claimed there was no signal. Do you think that's because the people at risk have already dropped out, or because in clinical trials only well people with very few comorbidities go into those studies?
Yeah, so either of those, or the third explanation, which is that there really is no risk when you look at the smaller dose or the lower dose, 5 milligram BID dose, which is exclusively used so far for rheumatoid arthritis in the US and all over the world. The 10 milligram dose is actually really interesting. So as you probably know very well, this was only marketed, or is only marketed, for ulcerative colitis, the second indication. And so in the trial, so outside of the oral surveillance trial, I don't think rheumatoid arthritis patients are treated with 10 milligram dose for tofa. So they have only been exposed to 5 milligram dose even in the trials. And when you look at this analysis that you mentioned, the event rates are really low. And when these event rates are low, it's really difficult to conclude anything from the trial data, because they are limited in both number of patients as well as time. So
excellent, excellent. So tell us a little bit about the methods, how you went about doing this study.
Yeah, so we used 3 large population-based data sources from the US. 2 of them, so these are insurance claims records. 2 of the databases cover patients who have commercial insurance claims or commercial insurance programs, and then 1 large federal insurance program, which is the Medicare, which covers everybody over the age of 65 in the US. So we used these insurance claims records to identify patients with rheumatoid arthritis who had been initiated either tofacitinib or, as a comparison, a TNF inhibitor, which are widely used first-line treatments. And prior to that, the cohort entry, we made sure that they did not have any exposure to any other biologic, just to make the population more homogeneous and comparable. And once we identify their treatment initiation, we look out for the signal of, or the outcome of interest, which is the venous thromboembolism. And in the primary analysis, we restricted this to venous thromboembolism events that were diagnosed within a hospital, because we feel slightly more confident about the outcome definition there being high positive predictive value if it's in a hospital, because with the insurance claims, one of the limitations is that there is no event adjudication. So we need to be more specific in definitions. In a secondary analysis.
Is that possible that in the US, and sometimes we do it here, they're treated as outpatients with some anticoagulation and don't get to hospital. Is it likely that you missed many for that reason, or is that not really done in the US?
It is done in the US, especially if it is a DVT. It is frequently managed outpatient, and so in a secondary analysis, we actually included both inpatient and outpatient events, and results did not change. So
okay, so that's reassuring. So I'm not sure if you know all the numbers, but before we look at the paper, can you give us a feel for what would be the expected VTE rate in an RA population, just on steroids and methotrexate, just on a TNF, like the British Registry published some data, and then we can kind of get a feel for what tofa does or doesn't do?
Right. So over the years, a number of people have tried to quantify the risk of VTE, which is high in inflammatory conditions like RA. And so overall, what we have seen in papers is around 0.5 to 1% point, meaning that if you follow out 100 patients for a year, you would probably get one or less than one event. So
0.5 to 1. Yeah.
I think it's not that frequent to begin with, but higher than general population because the condition is inflammatory. And for some other inflammatory condition like inflammatory bowel disease, they are actually slightly higher than that, for which again tofa and TNFs are used as well. So, but for RA, it's about 0.5 to 1% point.
And I saw the British Society published their numbers. It was 0.6 to 0.8 per 100 patient years in something like 14,000 TNF patients. So that's a feel for what the background is. So tell us anything we should know about these Medicare and these insurance things. There's nothing special about them, different. They're good representation of the population.
Yes, across the three, it's a good representation of the population, although I would mention that you would not see patients with lower socioeconomic background in any of these databases, because in the US, the insurance is tied closely to your employment. And so the two of the databases that we used, Optum and TrueVan, both represent people who are likely working or their spouses because their employer provides for their insurance. And the Medicare is more comprehensive, where if you turn the age of 65, you are qualified for that program. And so that's more comprehensive across the US. But other than that, I think these data sources across the three are population representative.
Excellent. And the key inclusion exclusions, there was nothing that would have eliminated patients at risk or anything?
So we actually did have some inclusion criteria which may have done this, but that is to ensure, again, homogeneity of the population, because here we are very much concerned about treatment selection, and we need to be assured that that's not explaining the results. So to do that, we excluded patients with cancer, which is a big risk factor for VTE, and patients who already have had an event for VTE. And the reason for doing that is that when you have these types of patients which have a higher risk of the event of interest that you're interested in, and if that is somehow also playing into treatment selection, it's likely to bias your treatment results. So in other words, people or physicians may sort of channel away from the treatment that they think may have an association with this event. So to homogenize the population, we excluded these two key sort of categories of patients. And
so no history of VTE were allowed in?
Yeah, that's right.
Okay.
And then we restricted to rheumatoid arthritis only. We did not look at IBD.
Fair enough. So any special characteristic of the population other than the Medicare was older than the other two?
Right. So Medicare was older. I think the average age was more than 70 by design, because that's the population it covers. The commercial insurance claims patients had, I think, in the mid 50s. Their average age was mid 50s, and Medicare patients were also slightly had a higher burden of comorbid conditions like diabetes or ischemic heart disease and things like that. Which is
interesting that up to 26% diabetes in that American population.
It is. Yeah, it is high, and believe it or not, it's increasing. So interesting.
That's huge. All right. So tell us a little bit about maybe the assessments and maybe some numbers and the findings. And one thing I wasn't quite clear from the paper, on kind of average, how long were people on TOFA in the study, if you know what I mean? How long on TNF?
Yeah, so we had on average patients followed for less than a year, and that is reflective of how poorly adherent on these treatments patients are in general in the routine care settings. And we did the as treated or per protocol type of analysis on purpose, because for safety events you want to minimize the exposure time misclassification. So you want to not follow patients when they are not taking the drug, basically. So in the primary analysis, we restricted the follow-up time only to the points or up to time point when they had continuous exposure to the drug. So on average for TOFA, I think it was less than a year. For TNF, around about a year or slightly more.
And the retention, just out of curiosity, what percentage churned off both treatments by 12 months?
Quite a bit. I would say for TOFA, I think it's 40 to 50% would be, yeah.
Oh.
And I mean, with the newer treatment, one other thing is administrative censoring as well. We stop accruing more data. So maybe it's possible that patients may continue taking the drug, but we just don't see it because we don't have.
And TNF's very similar, or TNF?
TNF is very similar, slightly higher retention, but more or less
not
similar.
much. Yeah. So tell us some numbers about, because you looked at very large patient populations with quite large, exposure.
Correct. So across the three databases, we had slightly less than, I think, 90,000 patients between the two treatment arms. For TNF inhibitors, a majority of them were TNF inhibitor user. It's not surprising because these are very popular or most widely used treatments. So 80,000 patients, I think, were on TNF inhibitors, and 6,700 patients on TOFA, which is the number that matters here. It is to date one of the largest study looking at this research question. So across the three databases, we had 6,700 patients on tofacitinib. And on average, as we discussed, about a year, slightly less than a year of exposure. So more than 5,000 person years of exposure on tofacitinib we had availability for.
So tell us a bit about your findings, please.
Yeah, so it's interesting. So I think I would like to take a step back and describe the finding from the previous paper, which again left us in this limbo of what's going on here. So in the previous paper, it was published in 2019, ANR, we had less than 2,000 patients, so 1,900 TOFA patients against, I think, 35,000 or so TNF patients. In that study, what we saw was that the point estimate for the hazard ratio was 1.33 or something similar, with a lower confidence limit of 0.78 for the hazard ratio. And so there what we concluded was that we were not able to sort of definitively rule out a signal. It was possible based on that data that signal may have been there, but we just could not detect it because of limited statistical power. And so we went into this study with the expectation that we will be able to include more recent data on a higher number of patients exposed to tofacitinib, and will give us a clearer picture. And that's exactly what we saw. And so in this study, what we saw was that across the three databases, the signal or the point estimate, the treatment effect estimate stabilized somewhat. So across the three databases, after confounding adjustment for many patient characteristics, the point estimate that we saw for tofacitinib versus TNF inhibitors was 1.13. And so it moved towards the null with additional data, which is, again, what you would hope to see if there is no true signal, is the early data stabilizes a bit, and then you would be able to more confidently say or rule out a large signal at least. So that's what we saw. We did not see any clear signal of harm with tofacitinib in the primary analysis or any of the secondary analysis. So in the secondary analysis, we looked at pulmonary embolism and DVT as separate outcomes. We did not find a signal there. As we mentioned before, we looked at inpatient or outpatient events for VTE. We did not find a signal there. And finally, we looked at a separate analysis, ITT, intent to treat analysis, just to account for the fact that many people are stopping the treatment. And so it is possible that if stopping the treatment is kind of prognostic of adverse events, we wanted to look into that as well. But even in the ITT, we did not see any signal. So across the board, we saw really stable results showing no hint of an elevated risk for VTE with 5 milligram BID tofacitinib dose.
Given that you had it,
yeah.
Sorry, go ahead.
Yeah, just wanted to wrap this up by saying that another important observation was that the events were relatively infrequent. So even within the 6,700 patients that we have on tofacitinib, we only had 29 events in the primary analysis. So it was infrequent and in the range of what was previously reported in I population, 0.5 to 1% point.
Perfect. I was just going to ask if you had a feel, given it's only a year study roughly that they're on the drug.
Yeah.
Were you able to see that all the events happened in the beginning, or they were randomly scattered throughout the 12 months?
Yeah.
Does longer exposure increase the rare events?
Yeah, that's a really interesting point. So, we were not able to look into this question specifically. On average, patients were only on the treatment for about 8 to 9 months. So we did not conduct analysis looking at cumulative dose. But that is something really on people's mind as well, because if there is a dose effect in terms of how much you are taking at a time, it is possible or biologically plausible that if you have a longer accumulation over a longer period of time, it may show up as a signal. But we were not able to say anything about that.
And what about risk factors? You looked at a number of risk factors. Can you tell us obesity, surgery, age, no prior history allowed in, and COX-2 seems to be an issue, but I couldn't find that in your paper.
Yeah, so we approached this from a causal inference framework. So basically our objective here was to account for all these factors by balancing those out between the two treatment groups in a way that the only difference across the two groups in measured characteristics is the treatment. And so we did not look at the individual contribution of these risk factors to the event of VTE because they were balanced out in the analysis. So in both treatment groups, they had similar prevalence or means for these risk factors.
Okay, because that's the kind of take-home message you might tell the clinician: be careful with this group, that group, whatever. So anything you'd recommend based on a risk factor profile to be careful, which group of patients to be careful?
Yeah, so I think based on the BARI results and based on the tofacitinib oral surveillance results, the regulators have actually already taken actions or steps to do this. So EMA, as you know, says that you should only use tofa for older patients if really there's no other option. And then FDA went a similar route, but slightly less sort of strict. They slapped on a black box for VTE if you had history of cardiovascular diseases or other risk factors. So I think it's going to be really hard to walk back from that. But overall, I think our study may be useful to reassure clinicians that it doesn't seem like a huge signal in your typical patients. If you have a patient for whom you think that the underlying risk or probability of these events is high, you probably still should avoid the tofacitinib. But overall, it doesn't seem like a huge signal for an average patient.
All right, so let's just be clear about that. There wasn't any particular risk factors that stood out in this study as patient groups to avoid.
Yeah,
we don't have to agree with the EMA decision or the FDA decision because I'm yet to be convinced they're evidence-based.
Right. No, that is true. I think, that is true. So we did not have the power to look at the subgroups specifically because of the limited number of events. So that is something that future studies may need to look into. But that our study by design did that somewhat with the Medicare split, right? So all the analysis were done separately in these databases. And so Medicare population is a high risk population. Patients older than 65 and age is the strongest risk factor, and everything else that comes along with that. And even in that database, we did not find a convincing signal. So I think based on what we did by design, it doesn't seem like a huge signal even among patients who are generally at a high risk for VTE. But again, we had a limited number of events there.
Excellent. So any other points or issues you want to bring up from your study and your paper? And we'll ask you to comment whether you think JAK selectivity is going to be beneficial or not beneficial in this area. Is it a class effect, if at all? Or is it a JAK2 inhibition effect, if at all?
Yeah, so so those are the questions. Unfortunately, are still unclear. The answers to those are still unclear and active areas of investigation. And with the oral surveillance, I think not only this side effect, but the other side effects will be rigorously pursued in studies like ours and others. But overall, I think the issue or the mechanistic insights into why the risk is higher is not clearly outlined. Is it a JAK inhibition effect? Is it an off-target effect? Nobody really seems to know the answer to this. The selectivity is another interesting issue. As you know very well, the newer agents are more selective, which one would hope that they haven't shown any sort of particular proclivity for this particular adverse event, the tofacitinib trial, for example, unlike BARI, which is JAK inhibition across the board. So it is possible, but at this point, it's too soon to know. And I think it's a really important drug class for the reasons we discussed earlier on. So I think safety investigations like this will be really important, not only in rheumatoid arthritis, but also in other conditions like IBD, for example, where this was more recently approved, but highly efficacious treatment. So,
and where do you think you'll take this research next? What's your plan? You moving on to another project, or are you going to keep going with this?
Yeah, so we are closely looking into the other outcomes, the cardiovascular outcomes, the MACE outcome, and cancer outcomes for tofacitinib. So we have been closely studying tofacitinib actually for a number of years. We published the infection paper in Lancet Rheumatology last year, where we showed or confirmed the signal for herpes zoster and some serious infections as well. This one was specific to VTE. But we are also actively looking into cardiovascular diseases. And there, I think the line of inquiry that we are taking is actually exactly along the lines that you were describing. So trying to understand this risk from the perspective of whether this risk is differential across different patient groups. I think that's a really key question, because if you look at oral surveillance, it was restricted to patients who had aged more than 50 years, as well as at least one cardiovascular risk factor. So that's a highly selective subgroup of RA population. And we appreciate that this is done to sort of maximize or minimize the requirement for sample size by increasing the baseline risk of RCT trial participants. But that's not the large majority of the RA patients. So looking at this question for all these safety events in the overall population is an area of our interest, and we are looking closely into that.
Would it be difficult for you to add BARI and UPA to your ongoing studies?
Yeah, so eventually we will have enough data to study BARI, but the unfortunate, or depending on how you see it, baricitinib is not that well uptaken in the market in the US. That's what we see in the early data. Tofacitinib is...
That's because you're restricted to the 2 milligram dose. There's very little evidence that that's the right decision. What about UPA, which must be more popular?
Tofacitinib seems to be selling well, but it's just too new to study. And I think down the road, the question that we discussed will be really interesting within class comparisons. Tofacitinib versus tofacitinib would be really interesting to look at.
we're already seeing switch JAK to JAK in our population. So
Yeah.
very interesting moving forward. And I think the JAKs are here to stay, and what we need to learn is how to use them the best and the safest. Can you just give us a take-home message for the clinician, and we'll thank you very much for your time.
Yeah, so the take-home message is that for VTE, for the routinely used 5 milligram BID dose in rheumatoid arthritis, we don't think there is a huge signal based on our updated analysis and the other data that's out there. So I think if you have a patient who seems to be doing well on tofa and doesn't have any additional risk factors, I think the probably the appropriate thing to do would be to monitor closely, but not sort of shy away from this treatment, because if this is really something that is shown to work well and really convenient for patients. So overall, for VTE, I think we can somewhat confidently say that there doesn't seem to be a big signal there.
So thank you again for your time. We greatly appreciate it. This is a very critically important issue for all practicing clinicians. In Australia, at least, the JAKs are up to 20-25% of the market in RA, with 1 in 3 MTX-IR going straight to a JAK, 1 in 3 TNF-IR going to a JAK. So clearly, we'd love to know, when you keep following these patients, bigger numbers, longer period of time, if you can determine whether cumulative dose has an effect. And if you can give us some risk factor information, that would be tremendously helpful moving forward. This has been the CSF Author Interview Podcast. If you'd like to know more about this paper and others uploaded to the CSF website this month, you'll get detailed slide sets are available in the publication section at cytokinesignaling.com. Please subscribe to this podcast on iTunes or wherever you get your podcasts from. Tell your friends that we interview very interesting people with very important papers, and let us know what you think. We'd love some feedback. So thank you very much. We thank you very much, Dr. Desai.
Thank you for having me.